Hi everyone, this is Dan from San Marcos, Texas BTS. I'm going to take you through a evaluation I did about a week ago. It's for a 33-year-old female with upper back shoulder pain. So like I said, 33 years old, customer service supervisor. This patient likes to run and exercise. She came in for referral for post-op C5, C6 disc removal shoulder pain. I examined her last week, and so the pain is coming from just right of her left scapula. She started having these symptoms after her disc replacement, which was about a month ago. Her photo scores are in the bottom there. You can check those out. So P1 is, like I said, along that left scapula, intermittent and variable, pretty low. It's between 0 and 2 out of 10. She described that as a deep ache. Also, she had numbness in her left fourth and fifth digits. It was intermittent, variable, non-painful, no other tingling anywhere else in the body. Here are the structures that I considered for my physical exam. You can look at those. Okay, so before my physical or my subjective, my primary hypothesis was muscle strain in the upper back. I also thought about adaptive muscle shortening causing pain, so upper cross syndrome, thoracic or cervical disc pathology, shoulder dysfunction with referral to the back, rib dysfunction, and a peripheral nerve irritation. Some ags and eases I found for P1, extending the head back. So that brought on her pain sometimes. It wasn't very consistent. Brought her up to that 2 out of 10, or I'm sorry, 2 out of 10. And then it eased after about 15 minutes. And also the patient felt like the pain came on randomly, especially when she was feeling tense. So some easing factors, she didn't really have a lot. She said mentally calming herself down seemed to work. So P2, not really any ags or eases, and she wasn't even that bothered with her finger numbness anyways. But those are the ones I listed right there. You can look at those. Okay, so sleep, her history, normal sleep pattern. This has been going on for about a month. She had similar issues before with her upper back pain, but it wasn't this bad before the surgery. So progression since onset, her symptoms seem to be getting better. She's only been to her doctor. Okay, so she's a pretty clean patient. No red flags, no yellow flags, no comorbidities. She's taking naproxen and Flexerol for her current condition. Okay, so some subjective asterisks I defined for P1, time for pain to resolve after onset. So we already had that at 15 minutes. We use that as a benchmark. And also the number of flare-ups per day in her upper back pain. For P2, I decided to use intensity of numbness in her fingers. So after the subjective exam, my primary and competing hypothesis were muscle strain and upper cross syndrome. And I didn't rule out anything in my subjective exam just because I didn't have anything like cancer listed in there, which I could rule out with a question. So everything required hands-on examination. So severity, I said that she was moderate severity. She is limited in her recreational function. She's always mentally worried about her pain when she's moving around, always worried about irritating it. And for irritability, I said moderate as well, just because the pain takes about 15 minutes to resolve. So the nature, I said it was musculoskeletal, soft tissue or joint related. Could be neural as well, but that's not really what I'm thinking. The stage of healing, I said subacute, just because it's been going on for about a month. And like I said, her symptoms are getting better. And also, I said before, these are pretty unstable and tough to reproduce, her upper back symptoms. So for planning for the physical exam, I thought that I would just use pretty much what's already in the upper quarter screen um, to figure out what's going on. Just use palpation of that affected area. Use active range motion, passive range motion. Check out the cervical and thoracic spine with CPAs. And so for what I didn't want to do is really mess her neck up, given that she just had a disc replacement. So I'm gonna defer some aggressive cervical passive range of motion, overpressure type stuff, and I think I'm gonna keep out the tick forward dick, other than the ULTTA for those same purposes. Okay, so precautions. Obviously she just had neck surgery, like I just finished saying, so we want to be gentle with that neck. Some postural observations. I noticed that she had moderate winging in her left scapula and a forward right shoulder. So for functional asterisk signs, I used neck extension, pain rating, and neck flexion range of motion. Yeah, I just used the upper quarter screen pretty much to rule out all the other joints that I wasn't really thinking were involved, but just for thoroughness, I just did that too. And so for her neuro screen, I found that she had normal myotomes, normal reflexes, and diminished sensation in her right C6 and C7 dermatomes. And also the patient had finger numbness in both hands with the ULTTA, but no reproduction of back pain symptoms. Here are her cervical range of motion findings. She's pretty limited on her left side, as you can see, but also limited everywhere. So for muscle length, I found that she was pretty tight, which you could assume, given those range motions. Her left levator and upper traps were pretty tight, and they reproduced her back pain symptoms. So that's kind of helping me form my primary hypothesis here. And then on her right shoulder, she had a tight pec minor. The left shoulder is pretty good. Also, so down here, she was pretty weak in her upper back. Those are some pretty low scores there. So starting to think about upper cross syndrome a little more now. Oh, and I want to mention she had pretty weak deep neck flexors as well. So I also could get some reproduction of pain with CPAs to T2 and T5. I wanted to do some shoulder tests just to check for like impingement. Hawkins Kennedy and Painful Arc were negative on her left shoulder. So I wanted, again, with the shoulder stuff, I wanted to check out scapular mobility, and I noticed that on her left shoulders, she had a poor upward rotation, which is probably coming from that levator, among other things. Yeah, the rest of this I've already said. Okay, so yeah, that's just about it for me. Get thinking about this, and I'll talk to you guys on Thursday. Okay, bye.